Recognize Mr. Wenstrup for the purpose of introducing one of our witnesses.
Thank you, Mr. Chairman. I'm pleased to recognize and introduce Dr. Gary Kirsh, who is a longtime friend and colleague from the Cincinnati area where we practiced in the same circles for many years. He is from a 35 urologist group in Cincinnati, Ohio. It's an independent urology company serving all regions of the Cincinnati metropolitan area, and I can tell you they do a great job. And they've really tried to coordinate care for patients where they operate and own their own surgical, imaging, laboratory, radiation, and clinical research services, which has been a large asset to our community. He's been instrumental in founding the large Urology Group Practice Association and has been involved with legislation and health policy for many years, and we appreciate that. And he is a graduate, got his medical degree in Chicago, did his residency in Cleveland, and we're glad that he chose Cincinnati to practice. And thank you, I yield back.
To round out the rest of our witnesses, we have Mike Lappin from Chicagoland. He's the Chief Integration Officer at Aurora Advocate Health. Brian DeBusk, President and CEO of DeRoyal. And Claire Sylvia, Attorney at Law at Phillips & Cohen. You each have 5 minutes. Dr. Kirsh, you're recognized.
There you go, sorry. Thank you, Mr. Chairman and Ranking Member Levin, and thank you, Congressman Wenstrup, for the generous introduction, and it's great to see you here again. I am a practicing physician, a urologist. I'm president of the Urology Group in Cincinnati, as the Congressman mentioned. I also represent an organization called the Large Urology Group Practice Association, known as LUGPA, and we represent the independent, freestanding urology group practices in the country, collectively providing about 35% of the nation's urology services. Our commitment to value-based care predates the ACA and MACRA, and LUGPA heartily embraces the Congress's vision of value-based care. Unfortunately, it's my duty to tell you and to report to you today that the vision of MACRA and value-based delivery is in serious jeopardy. According to CMS, currently only 5% of U.S. physicians are even participating in alternative payment model arrangements. More troubling, there are almost no APMs in the pipeline. In the 2.5 years that PTAC has been operational, only 26 APMs have been submitted for review. Of these, only 4 have been recommended for implementation and 6 for limited scale testing. Moreover, not a single PTAC recommended APM has been enacted by CMS. Last month, PTAC had a regularly scheduled meeting for hearing APM proposals from the medical community. The meeting was canceled due to a lack of submitted proposals. The Stark and associated fraud and abuse laws are one of the principal barriers to the development of alternative payment models. The Stark law was written nearly 30 years ago, as you know, and has not been substantially modified since 1993. Congress recognized long ago that the Stark Law was an obstacle to care coordination and value-based delivery when it authorized the Secretary of HHS to waive the self-referral and anti-kickback prohibitions for accountable care organizations. Yet, independent physician practices were left behind. Congress needs to, in our judgment, level the playing field to provide the same protections for independent physicians to test and participate in APMs that were offered to ACOs. While HHS can grant waivers to approved APMs, it's important to understand that organizations and practices wishing to engage in APM development find themselves in a catch-22. We cannot test an APM in the real world without financial waivers to Stark and anti-kickback laws, yet these waivers cannot be granted unless there is an approved APM. Organizations such as ours, frankly, may spend years of work and substantial investments designing an APM, but it remains a theoretical, mathematical model whose actual impact on patient care and healthcare financing is unknown without testing in the clinical environment. Moreover, case-by-case waivers granted by HHS are also typically narrow and cannot foresee real-world circumstances, such as evolving standards of care or new innovations or other circumstances that affect physician behavior and require modification of waivers. Stark Law additionally represents a barrier to APM adoption in that it prohibits compensation to physicians who receive revenue from designated health services based on the, quote, volume or value of their referrals to these services. While this makes sense in a fee-for-service model, and we do not dispute that, it is not relevant in alternative payment models under which practices accept risk and financial exposure to Medicare is limited. The volume or value prohibition prevents practices from utilizing revenue from designated health services to financially reward or penalize physicians for adherence or deviation from clinical best practice standards. Our ability to financially incentivize physicians for clinical pathway adherence is crucial to success in a value-based construct. Eliminating volume or value from stark prohibitions for the testing and operation of APMs would result in a clean, targeted, modernized version of the Stark and anti-kickback statutes. We must be able to pay for value, frankly, in a value-based arrangement. To be unable to pay for value in a value-based arrangement is sort of a non-starter, frankly. These are the reasons why LUGPA and 24 other diverse physician organizations have endorsed the Medicare Care Coordination Improvement Act, H.R. 4206, which eliminates the volume or value prohibition in APMs and also provides a means for HHS to grant waivers to test a proposed APM when it is submitted in writing and approved by the Secretary. Importantly, these waivers are not indefinite. They must be recertified on a semi-annual basis until the APM is approved or denied. We fully recognize there is no panacea that would transform healthcare delivery into a value-based system overnight. We do not advocate modification of the Stark Law as it relates to Medicare fee-for-service. That said, Stark Law must be modernized to allow for the creation of alternative payment models. These models represent innovative delivery systems that will increase care coordination, improve outcomes, and decrease cost. I thank you for your attention and would be happy to answer questions, Mr. Chairman.
Thank you. Mr. Lappin.
Thank you. Mr. Chairman,